most gadget, you see really basically the childbirth trauma which happens, it doesn't discriminate in tissues. So it will cause the damage to whole perineal body as well as the levator and eye muscle. So patient will have uterine prolapse, but along with the same time she can have anal or rectal prolapse also. So that is what actually partial rectal prolapse, only mucosa, submucosa. I mean, all of us know about pericordial prolapse, that means uterine descent, cystocele, rectocele, urethrocoele, and enterocele. But along with there is partial rectal prolapse or complete rectal prolapse can also be there. In complete rectal prolapse, basically circumferential full thickness protrusion of rectum through the anus, which may be intent or may be carcinated position is risk of strangulation. So dual is not very common, but quite often like at age we do see such cases. So you can see this is our own patient which we operated. So this patient had a 30 kg prolapse along with she had a big rectal prolapse also. So normally we tend to operate them in association with our certain colleagues, and or sometimes we do ourselves also. So this was our own case, and quite a few cases actually we have reported also. So while UV prolapse is common, rectal prolapse is rare in almost 2.5 per 10,000 per lakh people, and almost 50 to 30% of those with rectal prolapse have concomitant vaginal prolapse, typically rectocele or rectocele. So that means the childbirth trauma causes more damage to perineum, and there are more chances of having uterine prolapse than rectal prolapse. But if the patient has rectal prolapse, so chances of having rectal prolapse, uterine prolapse is less, but chances of having uterine prolapse with rectal prolapse will be more. So if someone will have rectal prolapse, usually will have that also, but it can happen otherwise also. And especially in children and all, sometimes interception etc. can cause pure rectal prolapse also, but we won't deal with that. That is separate topic altogether. And constipation is associated with rectal prolapse in 15 to 65% of patients. So constipation is a big, huge problem. So that is about 20 years back when I used to do PV examination, all recta used to be empty, and now every third alternate rectum is full of fibroids, and patients don't even realize it. So I don't know what is the reason for that. Maybe our changing food habits and all. But I mean, constipation has to be controlled, and not only that, constipation is a causative agent for prolapse. It is also you have to treat it to prevent basically recurrence of prolapse after surgery. So it may have a bearing on that also. So multifactorial etiology is there. So pelvic floor disorders like repeated pregnancy, childbirth, that is the single most important factor, causing stretching, tearing of endopelvic fascia, levator and muscle, vaginal body, and also the parental nerve damage also. Then connective tissue disorders like Ehlers-Danlos syndrome, so they have more tendency, their collagen tissue is poorer, so they can have prolapse of various organs, including genital prolapse and rectal prolapse. And genetic predisposition, like it happens in Indian collagen tissue may not be that good actually as compared to Caucasian and this Nigerian thing, and that's why many times we can have patients of nullipress prolapse also because of poor collagen tissue, so which is not related to childbirth trauma also. So the symptoms will be just like, I mean, all of us know about the bulge symptom, which we see in our genital prolapse, like sensation of vaginal bulge. You can see it, feel the pressure, heaviness, and patient can have the bladder is descending down. So patient will have because of cystocele, incontinence, urgency, frequency, weak or prolonged urinary stream, incomplete emptying. Sometimes they have to manually reduce it. So this is important for the postgraduate. If someone has to manually reduce the cystocele to pass urine, or she has to manually press on the rectocele to pass motion, so these are indications for surgery. So that is very important. And similarly, passing change to start to complete voiding. Sometimes some women have to stand up actually or in squatting posture to pass urine. So that is important. Same with the bowel symptom will be incontinence or bladder liquid. So this can happen with rectocele also as rectal prolapse. Feeling of incomplete emptying, straining, urgency, digital evacuation to complete defecation. Again, that is an indication of surgery. And splinting vagina or belly to start to complete defecation and mucus discharge. Then sexual symptoms can be there, pain in vagina, rectal, bladder, pelvic pain, low back pain. This pain is not very common actually in prolapse. In fact, quite often because of looseness, they may not have any pain. Rather, it's the other way around, that patient may feel sexual dysfunction for this reason, because everything is loose. Pain is less common, but it can really happen because of the low back pain and all. But what I want to say that some patient has got backache and all, and she has got prolapse, so don't give her realistic expectation. It may be related to orthopedic problem. So because patient will expect that after prolapse surgery she will have no pain in the back, that may not be possible. Sometimes it is not related to that, but sometimes it can be there. So history is important, like what is the age of the patient, urinary, bowel, sexual symptoms, occupation, obstetric history, like multipara and any childbirth, difficult childbirth before, menopause, smoking, chronic illness, surgical history, fracture, pelvic disorder. That's important. And physical examination, as before also in Dr. Kavita was talking in her talk. So neurological examination is very important. And of gait, spine. Normally in a normal gynae or obs case, we don't do neurological examination or neurological history, but that is very important in a case of prolapse, in a case of incontinence, and because that will be the cause. And sometimes the patient may have urinary problem. Dr. Lacha was also discussing in a lecture. So sometimes patient may have, like what sir was saying about diuretic and also what patient is taking medication. One of my patient has multiple sclerosis actually because of that incontinence. So it's important that we have cause known to us and rather than doing surgery for them from our side. So then physical local examination also important. Also for your position. Specify where you can do any degree of prolapse, third degree, second degree, recto, side specific defects. Examine cervical mucosa, examine mucosa, partial or complete rectal prolapse, petrous anal sphincter, opening mucus, direct fecal swelling is seen like in the case I showed you in the picture. Then urethra descent, stress incontinence, you can do Mohini test also. And then bladder, like midline, lateral or superior loss of support, cervical descent, rectocele and pterocele, perineal descent, pap smear. I won't go into detail, but it's better to do OPQ classification also for this patient. And after reducing the mass, you have to do dimension of the vaginal introit test, differentiate high rectocele and enterocele, levator muscle, anal tone, perineal body, size, position, and mobility. So when you are examining them, and you can also see associated any SUI to the patient also. And so after you do PV, after like reducing the mass, because it may be possible, one of the patient I remember, I have seen 3 or 4 patients, there was a massive retroperitoneal teratoma or mass which was pushing everything down. So there was nothing wrong with it, which was being pushed down. So had I done just vaginectomy for that patient, but then the whole tumor would have been remained. So in such case, you have to do dual surgery, abdominal, surgery to remove the lump plus vaginal hysterectomy that is needed. That is important. And so normally the patient has got concomitant both prolapsing prolapse, urinary prolapse as well as rectal prolapse. So if it's very mild, early stage 1, grade 1, 2, you can do observation also. Either to Kegels or pelvic floor exercise that will help in rectal prolapse as well as anal prolapse, mild to moderate, but not the tune which I showed in that picture. Then vaginal cones can be used for pessaries, electric stimulation of muscles as sir was mentioning in his talk. To repair of rectal prolapse as opposed to conservative management is typically recommended. Usually it doesn't respond that well to medical treatment, and because of potential for weakening of anal sphincter and rectal incarceration. So usually we have to do surgery for most of these patients, especially if they have concomitant grade 3 prolapse. So aim is to basically correct all defects and re-establish vaginal support at all levels to maintain, restore normal visceral sexual function, to improve patient symptoms and least risk of recurrence. And choice of operation will depend on the age of the patient, associated medical disease, degree and type of prolapse. Usually third degree is there, and then need for preservation of menstrual impurity and coital function, and concomitant interpelvic disease, skill and experience of surgeon. So as I was saying, the patient had associated abdominal mass, we have to remove that also. So normally, like for prolapse, we do vaginal approach. So any anterior defect repair. So if it is a cystocele, we do the cystocele repair, posterior defect rectocele repair, and enterocele repair. So when you are doing the posterior, this thing makes sure that we don't miss the enterocele. Quite often, the cause of word prolapse is failure of picking up enterocele at that time. So you have to put your finger in the rectum. Your finger, the highest point is above that. That means patient has got associated enterocele also. So whenever you are, and you should open the peritoneum in these patients so that we can know the cul-de-sac, and then we cut the cul-de-sac peritoneum and do that. Or when we do vaginal hysterectomy, we should do McCall's cultoplasty, as well as external and internal McCall's cultoplasty has to be done. That's important. And then if enterocele repair has to be done, then furtherly Manchester repair, the patient is young. So generally, if the patient is less than 35 years of age, family complete, then we do Manchester repair along with the ligation for such patient. Family not complete, then we avoid cutting amputation of the cervix for that patient. So younger patient, we can do Manchester. If the patient is very young or in nulli pes prolapse, then we do sling surgery, which we won't discuss, we don't have time for that. Then we can do sacrospinous hysterectomy also for the patient. That from vaginal end, we take a stitch, nylon or polyethylene stitch in the sacrospinous ligament, and at the same time we push the cervix up and take it in the cervix as low as possible in the cervix. So that's also we have done quite 7-8 cases now. Good results are there. And because other option is that you could have done abdominal sacropexy for this patient. So in that case, you can take a large polypropylene mesh, tie it to the cervix, and then tie it to the anterior sacral ligament or sacral promontory. So that can be done laparoscopically also, but we have got at least 7 or 8 patients done by other colleagues, not by us, and they are coming to us with rectal, with this massive open problem. And it because we just did last week only. There was a large mass erosion, which was failure once time. So this time we opened, so it had already perforated the rectum high up. It was so high we couldn't even reach it. So we did laparoscopy and we removed the mesh, tried to remove the mesh, but then there was a hole in the rectum high up. So we had to do, colostomy for that patient, and on the second sitting we will do that. So we are seeing so many patients of mesh erosion problem with the abdominal sacropexy, especially laparoscopic. So I don't know what's the reason for that. So we are very rarely doing abdominal sacropexy for that reason. Or if you are doing it, then you do it properly so that the peritoneum covers that mesh, because that is a big problem. In one patient, another we operated, she had the mesh had gone at 3 levels into the small bowel. So we had to do laparotomy vertical incision to remove that mesh. There were 3 holes in the bowel at 3 different levels. So 2 feet of the bowel had to be resected by our GI surgeon. Surgery 5-6 hours we were there. And the patients, so many such patients are coming. So please take care of mesh. And the US FDA has given warning for that. So don't use them so much. So these are the various operations. Then we can do Leaford operation, dual power modification also for this patient, and abdominal life-saving surgery, closed repair of enterocele, sacrocolpopexy, and laparoscopic approach like sacrocolpopexy, thoracolpopexy, scleropexy, robotic surgery. These are just different surgeries. But only problem of this laparoscopy and all, like if you don't close the peritoneum properly, then there is a lot of this problem. And for dual prolapse, we can do, both procedures can be done at the same time. So we usually call our Anita Tharmandi there in the surgery. We had done quite a few cases with her. So that can be done. In one case, like it was a very large rectal prolapse. So they did it from laparoscopic route. They did for the rectum they put at the high level, and from I did vaginostectomy for that. So in the same sitting, we could finish the whole procedure 45 minutes to 1 hour in the same sitting. Or otherwise, like I did vaginal bit and then they did rectal bit. So that can also be done. So you can do abdominal approach, perineal approach, combination of both transvaginal and transanal. Type of surgery could be naked tissue repair and mass repair, but masses we avoid these days, this thing. So in perineal approach, which is very common, we do vaginostectomy our bit, and the surgeons believe they did that part. Sometimes a very small anal prolapse and rectal prolapse. So as a gynae surgeon, we can ourselves do. So when we are doing complete, we go up to the anal mucosa thing. So when we repair the perineum itself, that takes care of grade 1 to 2 rectal prolapse. But if it is more than that, renal mucosa is coming down, then we do take the help of them. So this is you can say resolution symptom of rectal after repair of vaginal prolapse, report of 2 cases. And this posterior colporrhaphy we have all done, so that can also take care of this. And site-specific defect, I won't go into detail. So just like anterior repair, we do site-specific. Similarly, posterior repair, we do site-specific. These are the various things. Sometimes, like in the cystocele, we do the central part, but we miss the lateral part. So you have to take stitch in the lateral part also. But meshes are not to do with these things. So these are the defects. So site-specific defect we should do, otherwise the chance of failure are there. So normally graft can be pushed, but now we are not using grafts for this reason because of the mesh erosion problem. And these are the obliterative process. I won't go into detail, but Leaford, that means we just push everything up and we make 2 raw areas of the entire posterior wall, just close them, leaving 2 areas sideways for any fluid to come down. So these are the Leaford's operation. I'm not very fond of doing Leaford because whatever it is, usually we can very fast do vaginostectomy on these patients, and usually it also needs some anesthesia. But definitely, and patients sometimes feel that parts are closed, so psychologically simply upset. So usually, but can be done. Total colpopexy, partial colpopexy. And for rectal prolapse, I won't go into detail. Usually, surgeons do it. But like Here's operation is very commonly done at AIMS. It can be performed under local anesthesia also, so suitable for high risk patient, but not very commonly done. In that case, they used to use silver wire. Okay, and then the DUAL process is very commonly done at AIMS now. Like we did 3-4 cases, so Dr. Anita Thar from surgery department came, so she did DUAL for them. So in this case, rectal mucosa is removed and circumferentially from the prolapse rectum over its length. And then they tie the muscle is then plicated with a series of sutures, such that when they are tied, the rectal mucosa is concentrated toward the anal canal like that. So ultimately, prolapse is reduced and the ring of muscle is so almost just last 1 or 2 slides. Okay, so DUAL can be done. And the next slide is not coming, just 1 or 2 slides. Okay, so same way abdominal approach also can be done for their surgery, not our, and then, so they can do it like sacral colpopexy along with ventral rectopexy. Yeah, that can also be done. So basically rectopexy means rectum they pull it back in the abdominal cavity and then they either through sacral. This you can see. So sacral colpopexy along with ventral rectopexy. And combination approach, then both are. So usually that's what we do. Vaginal hysterectomy we do from vaginal route, and they do like laparoscopy or laparotomy route. They do the delivery operation for these patients. So this rectopexy they do. So this can be, or laparoscopic sacropexy plus ventral rectopexy can also be done for these patients. So this is my last slide. So concomitant uterovaginal and rectal prolapse. So take help of surgery colleague or GI colleague for that. So it is a multidisciplinary approach, and repair can be done by either perineal or abdominal approach, and good posterior compartment repair is to be done. That can successfully treat small anal or rectal prolapses, posterior colpoperineal repair. But if it's more than that, then you have to do like either Thier's repair, DeLorme procedure, or rarely you can do force clamp. So abdominal approach has high success rate, but slightly more complications. Combination can also come. So thank you very much.